Thank you for making it back. Wonderful session, last one, but that was just an appetizer. So we now get into the real stuff. Our first panel this morning, talking on total health system solution, reflections on the role of the private sector, is another star-studded panel. And allow me to introduce them, starting from very quickly from the far right. You have all the introductions in your book, so I will not go into detail. But on the far right is my good friend, Victor Kanyani. I think I've pronounced that better than most people. Victor is not only South African and a doctor, oncologist, but has spent his life between the public sector in senior administration in Free State Province into the private sector where he led the growth and expansion of Netcare, and since then has gone on to form even other institutions that are now making a difference to the people of South Africa. His wide experience and passion for this field is going to be useful as he helps us tackle this very, very complex problem. So, Victor, welcome. Next to Victor is Dr. Tim Evans, who by now is well known to you from last night. He is my boss, but he's also the Senior Director for HNP Global Affairs at the World Bank. Tim comes in with a wide range of training and experience in health as a physician, as an economist, spanning academic world, WHO, and now at the World Bank. Tim will give us a great insight from the global perspective on how things are moving in this area of public and private collaboration. Next to Tim is Jonathan Brumberg. Jonathan is the CEO of Discovery Health, which is South Africa's largest health insurer, a medical doctor too, and an economist. And over many years of working and advising in South Africa and other international bodies, is here with us to help us focus a little bit more on this area of health insurance, a big, big challenge, both to the old markets and the emerging markets. Then we have the only lady in the panel. This meeting is not very gender-friendly. But I think that she more than makes up for many women who may not be able to make it here, and that's Sangeeta Reddy. Sangeeta brings in a genetic, shall I say, genetic possession of the family being deeply involved, the starting of the Apollo Healthcare Group in India. That is probably now more than, I think that the second West-known Apollo, the first one was that thing that went to the moon or somewhere. And then there is this Apollo. Now I think that if you go anywhere, even in Africa, and say Apollo, they know what Apollo means. So she is born of that family, has grown into that family and that business, has been responsible for tremendous expansion of the Apollo Group outside of India to other parts of Asia and Africa. So she brings in the hands-on on the how to and when to and what to. And finally, last but not least, is the real moderator here, who's Dr. Kamia Kajavi, who is Senior Advisor in the Bureau of Global Health at USAID. Kamia joins us here with that nasty combination of JD and MD. When one is a doctor and is also a lawyer, and when you meet other doctors, they start wondering, what did I do wrong? But in this particular session, he will be moderating this powerful group to help us navigate the tough subject that they'll be addressing. Thank you very much, and welcome, Kavya.
Thank you very much, Kama. Good morning, everyone. I've already been introduced. I'm standing in for Ariel Pablos Mendez, who's been detained in Washington preparing Gail Smith for Senate confirmation hearings. She is hopefully soon going to be the next administrator at USAID. He sends his regards and his best wishes and hope for a productive and interesting two-day meeting. So just a word on the process that we're going to follow. I think we have maybe a little less than an hour and a half. The panelists are going to start a discussion rolling, hopefully with a little help from their moderator for about the first half of that time. And for about the last 40 minutes, we're going to throw it open to you all to pick up on the themes that they have touched on, pick up new themes, whatever you want. It's your meeting, of course. So my goal for the end of the session is to have a better sense from a kind of systems perspective on how the public and the private interact with each other, where they're going and where they should be going. Okay? So I'm actually going to, I think, contrary to the theme of the conference, I'm going to start with a couple of slides just to set some context once I figure out how to. There we go. We've been introduced already. So one of the things that we're going to spend a bit of time on is universal health coverage. Universal health coverage is getting the right care by the right person at the right cost to everybody. It's a very good organizing principle, both for service delivery and for funding of healthcare, financing, and it's something that that is getting a lot of traction. I spend a lot of time looking at sustainable development goals and the negotiation for the post-2015 agenda, and UHC is always high up on people's priority lists in healthcare. Another theme that's important to keep in mind is changing demographics and the rise of non-communicable diseases. So as we get better at treating childhood diseases and infections, and people are living longer, they're starting to get diseases in the countries where we work that are global. And these are going to be, if they're not already, the big killers: heart disease, respiratory, cancers, and so on. So we're going to be treating, if we look forward, an older population, more people for different things. The bubbles here kind of pick up on a theme that Dr. Shetty mentioned, which is namely that the lion's share of health resources is going to a very small part of the population, and most people are left uncovered, untreated. The other interesting thing actually to mention here on this slide is that things are changing economically. You all know that. GDP per capita is going up in a lot of the countries that were once very poor. That's a great thing, but it's a dangerous thing for health, because as countries go from low income to low middle income status, more of that, it's like Planck's constant. The more money you have, the more you're going to spend on healthcare. The problem is that as countries go from low to low middle income, a lot of that money is coming out of pocket, and it's coming out of pocket of the people who can least afford it. It's a huge reason for people falling back into poverty. It's a very important reason why we need universal health coverage. Again, infrastructure tends to be concentrated. Infrastructure and human resources for health tend to be concentrated in the rich countries. Poor countries don't have as much as they need, and even when they do have it, the quality is sometimes a little bit questionable. I'm going to leave this slide up because it's a bit of a kind of organizing framework. Down the side are basically what we all know as cost, quality, and access. And then across the top are the different aspects of the health system that we need to think about. So there's financing, service delivery, innovation and technology, and then getting human resources for health. So some of the themes that we're going to touch on are the role of the private sector in UHC, so private health insurance and so on, lessons learned from the private sector to date, and basically how the two sectors are going to work with each other, and then what NCDs mean for all of this. So that said, I'm going to ask Victor a question. Victor, may I ask you a question? So Victor has extensive health experience in both the private and the public sectors, and Perhaps Victor can talk to us a little bit about what he's seen on how these sectors interface, how they interact, what could be done better, what are the barriers to private sector growth?
Thank you very much for that question, and good morning, everybody. My insights are informed by my experience in Southern Africa, in particular South Africa and Lesotho, in that I only not just in South Africa, but also in Lesotho, which is our neighboring country to South Africa. All health systems have to attain certain goals, which include equity, responsiveness, but most importantly, to attain good health outcomes. And the private sector is part of that health system. It's not different from, it's not a different sector. It's actually part of the same national health system. It's important for the private sector to understand that role, that it's part of a national health system. It's not something separate from the national health system. But we also know that the private sector has an additional mandate. It's for, especially for profit, private sector has a profit motive. But that motive does not have to come at the risk of moving away from equity. It can be done in a way that also promotes equity and responsiveness. My experience is that sometimes there's a misunderstanding between the private and public sector about each other's roles. The private sector can achieve that for-profit motive through increased revenue by increasing volumes, not necessarily increasing costs. It can achieve that profit by reducing costs, by applying technology or working closely with the public sector in many ways. So in a sense, although there is some differences, there are also a lot of common areas that can be shared between the two. And what I found to be the ingredients of a good interaction is where there's understanding of the two different sectors and how they come together and how they could work together. It starts, first of all, there has to be trust that each sector is focusing on the same goals, and that is they're not competing, but basically working together towards the same goals. The second issue is about creating an environment for both sectors to work. The government has to create an enabling environment for the private sector to thrive, so it can actually provide that type of support. You require, the government has to be open-minded, allow innovation, and not try to actually pull back the private sector in any sense. So my experience has been that where you find political will in the public sector, you actually find a very responsive and very innovative private sector coming to the party to assist government to achieve its national goals. So I think the most important ingredient is actually about trust, is about political will, is creating the right environment for that process to start. Thank you.
Would the panel like to comment on that? So is this working? Yeah? Okay. What are the things that you've seen that have succeeded in being able to promote that trust? So, I mean, one thing that might come to mind is cycling of staff between the two sectors, that sort of thing. What's worked in the past in your experience?
What has worked in particular in Lesotho is where the public sector was actually open to ideas, very open to innovation. And they were willing to take that risk with the private sector to actually say, hey, acknowledging their own weaknesses, acknowledging where they actually needed help, and said, can you come with solutions for our problems? That has worked very well. In certain areas, for example, in South Africa, where you find government a bit resistant to actually engage, you actually found that things do not go very well. So it goes very well where you find a very mature public sector that's willing to engage, willing to learn. We have too much dogma, I think, in our health systems, where people are saying, we have done it this way, and only government can deliver on this thing. This commodity is unique. It's different from any other commodity. So you cannot apply the same, economics in terms of healthcare. Fine. The issue is that by nature, governments are not very innovative. They're not very responsive, and that's what private sector could bring to the party. And I found it working where you find a government that's actually willing to take risk a bit, to actually acknowledge its weaknesses and acknowledge that there is some good you can actually get from the private sector, and that way able to move forward with the private sector.
Are there things that might be the sort of the thin end of the wedge in terms of creating trust? So, for example, would the government be more receptive to sort of pharmaceuticals versus service delivery versus health insurance? Where are the places where the government you think might be more open to accepting the private sector than creates more of a mentality of trust?
I think it's probably easier for government to deal with commodities, things they're actually buying from, that they actually bring in, to, better than in provision. Because historically, they've been in the provision side. They actually believe that's actually their terrain. And therefore, they found it difficult to allow anybody else to come into that space. So I found it easier for them to maybe to work closer with device and pharmaceutical manufacturers to actually supply them rather than the other way around. Even then, they still focus on a much more traditional procurement. They still want to go out on a tender, buy, and that's it, and not try and find innovative ways of ownership. Very still rigid about they want to own everything they have. They're not looking at other ways of doing that. I think there is a change, coming slowly, at least in experience in Africa, that governments are now trying to look at other ways of ownership. But historically, governments, like to own things and actually are not open to new ideas of saying you don't actually have to own the thing as long as it can actually achieve your goals. Maybe that's the way to go. I found that on the provision side, governments are much more, demanding. They want to have to own that space in a sense.
Things that are more sort of inherently governmental, they want to keep hold on, that they consider.
Yes.
Tim, did you want to add to that?
Yeah, no, I just, from my perspective, where we deal with a lot of client ministries of health, I think one of the things in building trust is also building capacity to understand the different points of entry for the private sector to be a critical complement or arm's length implementer for achieving the health sector's goals as a whole, and moving away from what I think is an antiquated notion that the Ministry of Health is the fully integrated health sector in and of itself. And I think that's a mischaracterization of virtually any healthcare economy in the world. And so I think where we see a common constraint across many countries is that there's very little endogenous capacity within ministries of health to work with and understand the private sector. When I say that, I mean it not only in the context of understanding opportunities for contracting and public-private partnerships and full outsourcing and better procurement, et cetera, but also in very important areas of regulation and regulatory frameworks. We see sometimes, or very often, that these are unfunded mandates. They don't have critical staff, and therefore they're not providing that foundation which really makes it clear what the rules of the game are and allow transparent, formal engagement of the private sector.
Okay, good, thank you. Okay. Johnny, would you maybe care to comment on, we're jumping ahead a little bit about UHC, to put this in the context of universal health coverage. Do you see openness on the part of government to private partners in UHC, or not? And if not, how do we get them there?
Thanks. Yeah, I think it's very hard to generalize on any of these questions, to be honest. There's so many differences between the attitudes of government in different countries, different parts of the world. And I think we see the full spectrum. So countries that are extremely closed, very ideological in their government approach to any role for the private sector, i.e. there's none, right to the other extreme. I think that Tim's use of the World Health Economy is a very, very useful construct, because it does give a sense of that health systems around the world are actually diverse economies made up of public and private sector actors. And I think the brilliant opening talk this morning makes it abundantly clear to all of us that health systems around the world, health economies are on the brink of such incredibly rapid change. If you think about technology, how patients are coming increasingly to become informed consumers, advances in genomics, all of that. And I think that huge innovations are within reach. And they really are, I think if we're honest with ourselves, only going to come from the private sector. And so my view is that governments around the world, really, it's inevitable that governments embrace innovation and in the role of different private sector actors. And that it's just a question of the pace at which they do that and the particular entry points, as Tim says. But I think this kind of quite old-fashioned debate about is there a role for the private sector is way behind us in reality. It's just a question of how and when.
Sankita, could you maybe pick up on the theme that Johnny just raised about changes in technology, changes in maybe sort of patients' attitudes? What in India and in your business is really changing the game for you, and how are you responding to it?
So, I think in opening I must say that anything you say about India is true. If we say that you have a tremendous, outstanding healthcare system which is attracting patients from across the world, it's absolutely true. And if you also say that you have a terrible health system, you haven't met your MDG goals, and there's a baby dying every 10 seconds, that is also true. So India is truly islands of excellence in an ocean of inadequacy, but just buoyed by a tremendous potential or a capability. There is a mood out there to get things happening. And I think the fact that we have 850 million cell phone users is a non-trivial fact. What's waiting to happen is for us to put the right kind of health empowerment onto that phone and change the way people use technology. I believe that we're on the cusp of an Uberization of healthcare, and customers never cared whether it's public or private, as was very appropriately said in the morning comment, and I strongly believe that the customer knows how to navigate between a public and a private sector provider very easily. That paradigm was broken a long time ago, especially in India, where 80% of care comes from the private sector. 60% of the doctors being graduated are from private medical colleges. The almost 70% of nurses being graduated are from private nursing schools. So it's a complete private wave. What we're needing is a few things, and I think the first and the biggest and the most important one is that common vision of how these two very important skill sectors really work together towards a common universal health coverage. And an appreciation of the fact that health coverage is a range of things. It is primary health care when you need it appropriately with an effective overlay to ensure that the burden of NCD reduces. It's emergency care so that the mother can get to the delivery home and have that baby at the right time. It's advanced tertiary care, and if Apollo has been able to do close to 200,000 heart surgeries at 99.7% success rate, on par with any of the best institutions in the world, at below $2,000, then that's a replicable trick for health systems in India and in other parts of the world. So nobody should die for lack of a heart surgery or a renal transplant or an organ transplant. Last week we did 23 organ transplants in a single day in a single institution. So this kind of scale is possible and quality is possible. And to move away from the hospitals that we used to have in India, which were held by one individual and took the personal dynamism and the charisma of that individual to literally hold them together, like my father or Dr. Shetty, you're now seeing an ability to standardize, to protocolize, to Uberize, to put that technology overlay, so that today, when I open my phone or my iPad, I see 57 hospitals. We've demystified quality into 50 measurable elements. Those measurable elements are quantified and put into a parameter every day. That parameter is uploaded. It goes into a dashboard. The dashboard has a metric. The metric is globally benchmarked. That's translated into a color. So I know if one small hospital in Karur is an amber, I know that somebody's going to respond. And if it stays amber, double amber, that means they haven't done what they need to. So in 24 hours, I will be calling. So when you put technology, quality, passion, capability into a system, you can create scale, and that scale can enable universal access. So it's a combination, it's a blueprint, and it is an orchestra. We are beyond, healthcare is too complex for it to be a single talented violinist. The world of healthcare is an orchestra. We need to play together. And in a room so full of talent and capability and diversity, I think that is really one of the biggest joint learnings that I would love to really have, is that how do we enable this blueprint to access global capabilities from everywhere, to create the next paradigm of healthcare, which is technology enabled. And I want to add just one more point, which is very, very important and but is again technology based, is that the onus and responsibility for healthcare. For a very long time, people said, it's my doctor. Then they said, it's the government. At some point, it was the family. And now, it is the individual, seriously empowered by knowledge, but also living in a construct of society. And so it is in that construct of research, innovation, SMAC, technology, the food you eat, the pollution. It's that combination of healthcare as society's responsibility, which I think will take us to that next vision that our children and our grandchildren will live in a healthier world. And it goes beyond the finance and the economics and the skills. It's the mindset to do that for the next generation.
Wow.
Sorry.
Tim, did you want to come in?
Yeah, it's never good to come after a comment like that. So we need some space here. No, those are fantastic comments. Just on UHC, I want to pick up with a couple of things this morning from Dr. Shetty's, Professor Shetty's excellent keynote. But he talked about UHC, or really, we were not in the business of scaling charity, but good business practice. And I think that's true. But I want to say that UHC is about scaling values. And values can be scaled. And if there's a value that everyone, anywhere, deserves access to good quality care without being pushed into poverty to access that care, then that is a rallying value. And I think that's why we put that out in front of us at the World Bank Group. And we think that that's a value that both the public and private sectors, however you define them, can rally around. The second value is that growth in health and healthcare is good. We're not afraid of growth. It's a great investment. We know that investing in young children, yes, investing in adults, is the human capital basis that fuels the economy. We have great evidence that 25% of full income growth over the last decade in low and middle income countries is a function of improving life expectancy. Okay? And as we heard this morning as well, it's a great business. It's one of the largest and fastest growing employers in the world as a sector. All right? It is very pro-women in terms of the composition of the workforce. It's an entry point from informal engagement and existence to, or livelihoods, to formal employment and career ladders. And there are literally dozens and dozens of businesses that spin off and interact with the healthcare industry. So I'm saying that deliberately because often when we go and see a minister of finance, the minister of finance says, geez, you know, we really want to cut expenditure in the health sector. It's an inefficient consumption sector. And there's really a short-term and blind nature to that perception, which is missing this bigger picture. So I'm emphasizing that because universal health coverage is not scaling charity. It's really growing a vital sector of the economy, which you know, if you do it well, is going to have multiple positive, as we call it in economics terms, externalities. And so it's really a great investment. But there are some problems. At the moment, if we look at the private sector, one could argue you're much too focused on high margins and low volume. You're skimming off the top to small parts of the population that can pay very high prices, which in the short term is good business. But the longer term and much more interesting business is lower margins and much higher volume. Right? And so the transformation that I took away from Professor Shetty's talk and some of the panelists here is how do you fuel that transformation to much higher volumes and lower margins? So in my own country, Canada, the physicians boycotted, walked out in 1962 when the province of Saskatchewan passed the Medical Care Act, because they said they wanted nothing to do with socialized medicine. Okay? They wanted to continue their private practices. Right? They felt this was an infringement of the state on their liberties. Well, the irony of that is that every physician in the province of Saskatchewan, and also many South Africans who came to work in Saskatchewan because there weren't enough Canadian physicians to work in Saskatchewan, have done enormously well in the last 50 years, in part because the health sector has grown in so many ways. So you've moved to a situation whereby guaranteeing access to the full population, actually the market has expanded. And there are many more physicians doing much better with a larger volume of patients than would have been otherwise. However, you can have too much care. And we've seen, for example, in fee-for-service systems, that there's a tendency to, if you give that doctor the pen, if you give them access to the cath lab, then every patient that comes in is suspected coronary artery disease until proven otherwise by the expensive treatment or expensive intervention. And there was how many of you follow Freakonomics? Right? Okay, and so some of you may have seen a very interesting study that was done recently in which they looked at the impact on outcomes of patients with heart disease at the time of the American Society of Cardiology conference, when all the cardiologists go to Prague or New Orleans and have fun or learn for 5 days, work hard, but their hospitals are relatively understaffed. And so what do you think was the impact on patient outcomes when the experts were away? Did they improve or get worse? They improved, right? And so these are things where I think there's another value inherent in what we're talking about universal health coverage, is that neither the public nor the private sector have the monopoly on achieving these core outcomes of availability, quality, and affordability. And we really have to challenge one another with clear evidence on what it is we're delivering with respect to those hard outcomes and how we're getting there. and hold ourselves accountable to those outcomes, and therefore be agnostic. Because in the eyes of the patient, I would agree entirely, they don't care whether you're public, private, or some combination thereof. What they're very interested is making sure that whatever religious denomination of sectoral denomination you might might go by, that you can deliver those outcomes in a consistent way for the population.
Victor?
I think the other two challenges that have maybe criticisms that are faced by the private sector is, one is issue of curative care. There's a belief that private sector is interested only in curative care and not necessarily in prevention and those good issues in healthcare. So I think it's important for the private sector to understand that criticism as how it actually promotes that as well, not just focus on curative care, which is probably the more expensive side of healthcare, but also be involved in prevention and health education. The other one is about training of health professionals. There's a belief that private sector is not training enough. It's just out there to poach the good guys from the public sector. And I think it's important for the private sector to also deal with that particular challenge and also get involved in training of health professionals. Obviously, require enabling legislation, enabling environment for you to actually get involved there. In the number of countries where private sector is now allowed to train health professionals. In other countries, there's a limitation on what you can do to train health professionals. So I think those are the two areas that probably also require a bit of innovation from the private sector to show that they actually can be trusted as a partner and they're actually part of the bigger health system.
Johnny, did you want to come?
Yeah, I thought just to add a couple of thoughts to this very interesting conversation. I think clearly I've had some fantastic conversations with many of you at the conference, and what's very clear is the amazing range of things that are being done in the private sector already. And Tim's made the point that the delivery of healthcare is just enormously complex. So from collection of premiums, payment of claims, management of risk, delivery of renal dialysis, heart surgery, there's just any number of chronic disease management, there's any number of sub-elements of service delivery that are required. And I don't think anybody here or anywhere would want to argue that governments have a monopoly on how to do that. So particularly, I think, as systems become more complex, the role for private innovation, private entrepreneurship, private capital must actually be getting much bigger and more important rather than the other way around. Victor mentions prevention, and I thought it might be interesting for me to share with the conference just some experience we've had at Discovery, going back now nearly 20 years, with trying to change the behavior of our clients to improve their health and wellness. So we're a health insurer originally, now in life insurance as well, and I think maybe even before the term behavioral economics was formally coined and became a huge discipline as it is, we had this, my colleagues had this insight that people defer the painful things they need to do to improve their health and bring into the present pleasure and enjoyment. And so we designed a system, it's called Vitality, but really where the idea was make access to healthy lifestyle easy. So provide very big subsidies, up to 100% for gym, for exercise, for healthy food, and provide information and knowledge, and then reward people through heavy discounts on things like flight or travel and through lower premiums when they look after their health. And so that's a program that we developed. It now has approaching 4 million clients worldwide in South Africa, but in many other countries. But the most amazing thing about it is we now have nearly 20 years of hard data that demonstrate what happens to these people when they're given the information and the tools to improve their health. So we have, at age 65, if you're with us and engaged in our program, your life expectancy is 8 years longer than somebody who's not engaged in the program. Healthcare costs across our entire base are 4% lower for people who are engaged than are not. Hospital admissions are 10% lower. Hospital costs per admission are 25% lower. So these are, it's very, very hard data over literally millions of life years We're now rolling this into a number of products all over the world, both developed and emerging countries, all over Asia, China, Europe, etc., mainly with life insurance, by the way, because the reinsurers and the life insurers can see the power of offering lower premiums and then keeping them lower if people will genuinely engage with improving their health. I'm telling this long story really mainly to make the point about innovation, that this is a 20-year-old innovation, comes out of the private sector. We're struggling to persuade governments around the world, some of them are keener than others, to take this on themselves. And we're doing this now in South Africa with several local authorities and provincial governments in schools to try and work with schools to improve the health of school children.
So I'd be a little curious as to what the barriers are. And by the way, that fits very nicely with what Sangeeta was saying about the patient being empowered. But I think, Tim, you wanted to
Yeah, no, I just
add
want to
something.
build on John's comments. And I think I'm a little concerned that we don't preserve or entrench what I think is a 20th century bipolar world, which was either the public or the private sector. I think both experiments in health have failed miserably. So if you think that you can centrally control and plan everything, everything's owned by the public and run by the public, there really isn't a healthcare economy in the world that follows that. Likewise, you can't outsource to the invisible hand of the market. We know healthcare is such that it has, classic market failures going back to, Kenneth Arrow's seminal piece in the 1960s. So I think what we're looking at then is something which is much more of a hybrid. And I think this relates to the complexity of the sector. And so it's not an exclusionary codependence, it's an inclusionary one, whereby one has to embrace the plurality, right? So if we're really going to go forward on the IT in health revolution, okay, the Minister of Health in Uganda declared a moratorium in 2012 on all new IT applications in health. Why? Because they had a new ICD disease classification called pilotitis, right? They had so many pilots all across the country, all with different private sector engagement and public sector, NGO, multilaterals, all trying their different little things, many of which look the same, and there was no foundation to support or to scale those innovations, or even assess them systematically, right? So it wasn't that they were saying these things are bad, it's just that there has to be some system to really look at how to systematically evaluate them so that you can have some coherence and performance which can really go system-wide. And so it really is that understanding of that intersection and then trying to figure out how to manage that complexity in real time, because there isn't either a silver bullet or a one-size-fits-all. But it does take some concerted expectation, and for the Minister of Health at that time, they said, well, we need to take a time out and look at this. So I give that as one example of this codependence and the need for active engagement of both the public and private and other actors in a much more pluralistic governance of the health sector.
Sangeeta?
A slightly allied comment. I think that while the lines between the public and the private are blurring, I also think the lines between the payer and the provider are blurring. And it's in that environment, along with the complexity of choosing IT based on Tim's comments, that I want to share that the government of India actually had a joint committee of both public and private providers and policymakers, and chose a framework and a structure for a national electronic health record. They bought a national license for SNOMED, so our nomenclature would all be common. And if we genuinely believe that the world is moving towards analytics and data will be shared, etc., I think it's a significant initiative that every government should take up to visualize where this is going, because while free markets and privatization is important, at some point, data needs to consolidate. And the easier you make it to do, the less money you will put into non-medical provisioning. Because in a complex environment, I think in the US, every dollar spent, there's 8 cents going into back end.
It's more than that.
It may be more. Somebody said 16. I was trying to be kind. My hope is, my genuine hope is that India will ensure that we spend less than 5 paisa per rupee on back end. And towards that, we have made linkages between the insurance companies and the providers. We're creating a common agency in the middle for identification, common billing format so that it will be easier, and then mobile enablement. So there is some smart thinking going behind the IT, and I think that's an important place to go. The second one that I really want to share is that almost 17 years ago, Bill Clinton visited India, and one of the things that he did was he pressed a button which gave access to a small village of only 7,000 people, which was the place where my father was born. But he gave telemedicine access to that village to our super specialty hospitals in 3 other cities. And from that day, 17 years ago, the telemedicine initiative has grown, evolved, moved across boundaries of geography and nationality. And today we do approximately 700 teleconsults a day from different parts of the world, and we're just set to take that on an exponential leap. And I think that remote care has tremendous possibilities because, 80% of India's doctors live in 27 cities. Rural India, where 70% of the population has less than 5% of the doctors. So the demographic points towards remote care, and I think it's the same across many countries, including developing countries. Rural America has problem with second opinion services. And we need to break down legislative barriers or other barriers which are preventing remote care from being global. And that will enable access. And if you overlay the paradigm of high volumes and low margins onto remote care, and then if you overlay the paradigm of public and private, and then if you say the boundaries between payer and provider, and then if you empower the individual so that he knows that, yes, this neurologist or this neuroscientist, surgeon who's done 500 different surgeries, and this is a success rate, they know where to go. So I can wax eloquent on remote care. I know we're running out of time, but I just wanted to leave this really smart group of people with this thought that in whichever capacity we can, if we genuinely believe in universal access, low cost and high quality, we must equally push standardization of IT and universalization of remote care, because that is the key which will open up or break down many, many barriers and silos which are preventing people from getting care.
Tim.
Yeah, I just wanted to take Sangeeta's sort of layered approach and add one more layer, which is what I would call global health markets. It relates to this codependence, which is that a lot of what happens within a country is not a function of what the government sector or the private sector in that country are dealing with. And it's obvious in some areas. For example, the pharmaceutical market is increasingly globalized. But I just wanted to give 2 examples of work that we're involved in. First, on looking at the problem of tuberculosis in the mining industry in southern Africa. You have some of the highest rates of TB, which have been very resistant to efforts by mining companies to treat tuberculosis. And part of that problem relates to the population of workers that come from across 4 different countries in southern Africa. And so when they go home to Lesotho or Swaziland or Botswana, they don't have continuity of care. So you have a cross-border issue, which is very difficult in terms of the standards and issues related to patient follow-up, information systems in different healthcare systems. And so there's a very interesting project taking place that the bank and other partners are involved in, which is really looking at how to standardize care to ensure continuity across borders. And I think this is indicative of this codependence. Another example is the global financial markets, where in something called the International Financing Facility for Immunization, we've looked to leverage capital markets to guarantee financing for universal child immunization. And this has been something that's been done together between the bank and the Global Alliance for Vaccines and Immunization, or Gavi. But it's really an innovative way of selling what in many respects was an immunization bond, and then having the return on that bond guaranteed by a number of development partners who were prepared to provide a certain rate of return, and the bank guaranteed the bond with its AAA rating. And this global financing and the innovation on global finance is one that we're currently looking at in the context of pandemic emergency preparedness. And what we've found, for example, is the insurance companies and reinsurance companies are very interested in the pandemic risk market, right? So these are, I'm just saying that these are other entry points where I think the private sector is incredibly important if we think about global healthcare markets.
Sangeeta, yeah.
Okay, so I just wanted to add one more line to that, and that is that it's important to think about health holistically. So we're doing one pilot with just 7,000 people, and it's actually not a pilot, it's a showcase, because I believe pilotized is scary as well, but 70,000 people. Everything from sanitation to a school to immunization to 100% screening of cancer to kitchen garden and yoga and alternate health. And I think that whichever silo of healthcare we belong to, we must reconstruct holistic healthcare at every point of time. The second very quick comment I want to make is if we sit back and wonder, why don't the governments get it or why don't people get it? I think it's because the world has become very driven by a focus on GDP. Can we as healthcare professionals seek for an equal importance to a global health index? And government should focus equally on how they're growing their economy as well as how they're saving their babies or how they're preventing NCDs, because NCDs will overtake any economy if you do not give it a long-term focus. It is not a quick fix item. So with this appeal to create a global health index, and I think between World Bank and IFC and USAID and everyone in this room, we must ask for more positioning for healthcare and not sit back wondering why don't they get it.
Very good. John, did you want to?
I wanted to just make sure that as we've thought about why governments do and don't embrace private healthcare providers and funders and so on as part of their solutions, that we understand also some of the nuances of other constraints on this kind of innovation. And I think some of what we heard in the brilliant talk this morning about the global and growing shortage of health professionals is a relevant issue. And I'd like to, I think, draw attention to not only the shortage, but the fact that in many health economies, health professionals, and doctors in particular, can actually be a force of reaction and conservatism. So, and with great respect to my colleague, I'm a doctor myself, several of us are on this panel. It's not to speak negatively of the profession, but to say that the medical profession is often in a position of great power. That power is increasing as the shortages become more and more manifest, and that power often benefits from the status quo. I was, stimulated to think of this, Sangeeta, by thinking about in countries, some countries that I know well, the tremendously negative reaction of the organized medical profession to remote healthcare, to telemedicine, to virtual consultations, and so on. It's kind of, the knee-jerk reaction often is shut it down because it's a threat to our livelihood. So I think that any serious change in healthcare systems does also need to bring the organized health professions along and help them see themselves, help doctors see themselves as agents of innovation and change, and to move away from this otherwise knee-jerk reaction of let's leave things like they are. We're very happy with the status quo.
Good. Great. Thank you for your comments. Let's open it up to the audience for discussion. If you could go to the microphone, please. Please tell us who you are and your question. Just line up at the mic.
My name is Mustafa Hunter. I'm from Egypt, and I've been working in these corporate governance, CSR, impact investing, and private sector participation in healthcare. And I would like to come back to the fundamentals, which is that we're debating public and private. If we remove the private sector from healthcare, we'll be remaining with a naked doctor, sorry to say it but actually every single thing you use in healthcare is produced in the private sector. So we're speaking simply, are you buying a product or buying an asset, or you're running it yourself? But at the end of the day, I would rather to bring the perspective of this public asset management perspective. We have money on behalf of people. Economy losses in other industries are nice, but here, if you lose profit in other industries, here there is one patient maybe who died because you were mismanaging these resources. So the decisive point here is, why are we actually using the private sector? And this is, if you're looking into this total health solution, we need to strategize on that. Is it for efficiency? Is it to bridge financial gaps? Is it for outreach? And if this question not answered, because at the end of the day, we're using money on behalf of patients to give them the best solution, and we should be held accountable for these inefficiencies, which is the second question, or the main question I'd like to pose. In the global system, what is the accountable system for mismanaging resources that are paid for that? And if we are in the private sector bound to returns of investment that every CEO has to do, what are the returns of investments calculated for this money, and how much money is actually that? So how can we strategize on the private sector and put this as why are we bringing that? Because maybe we're using a fork to drink a soup and then we blame both of them. Thank you.
Okay. Let's take 2 or 3 questions and then we'll respond.
I'm Sharvani Chakraborty from Merck, Germany. I actually have a question for Dr. Evans. This is 2015. Most likely in September, if you're lucky, the universal health coverage goals will be adopted. But I'm a little bit scared, actually. And I should mention I used to work with the World Bank, and I worked a lot with governments, and what I found is presidents are committing to universal health coverage, but then ministries of finance get very worried when the money is not used appropriately. So for me, universal health coverage is a supply-side litmus test. And how are we going to do this without the private sector? We know that private financing is going to continue. There's going to be private provision. So I'm looking to Dr. Evans for getting us started on a disruptive innovation to bring the private sector into universal health coverage. Thank you.
Very good. Let's have one from this side.
Hello. Hi, yeah. Rob McDonald from Meridian Capital. We have some healthcare investments. A lot of discussion, just to refer back to the first speaker, who mentioned that there are a lot of vested interests in that oppose change in the medical world. And most of those vested interests, in our limited experience, seem to come from the doctor community more than anything else. You talk about, in this session, about the relationship between the private sector and the government sector, but what we're finding more important than that is reaching out to the actual system users themselves, the patients. And what we think will drive change in the future will become patients becoming better informed and able to make choices themselves as to which sector suits them better and in which direction they choose to go. So the question is, what does the panel see as the optimum way going forward of reaching out to the patient community and educating them better on how to find the best level of care themselves. Thank you.
Okay. So we have a question on what sounds like public sector stewardship of health funds. We have a question on how to actually get the private sector involved in UHC schemes, and we have a question on mobilizing the people. Who would like to start?
Tim, I guess. You?
Yeah, well, I'm ready. I'm happy to take a crack. There was one that was addressed to me directly, which is unfair because Sharbani knows too much about the World Bank, having worked there. I do want to just make a quick comment on the standards for accountability. I think this is really important. And it's an area that we often take for granted because we associate, and the health sector is an information-intensive sector, but often the parameters of performance that we need to measure aren't being measured systematically, and the systems for those measures are not in place. So let's take one that's incredibly pertinent to this audience. If we look at the system of national health accounts, they've been very poor at understanding what the magnitude and nature of expenditures is in the private sector. Initially, the national health accounts were entirely public sector biased. And so we're missing in our assessments of what's being spent in health systems the whole private sector. Now, there have been efforts to improve that, but if you don't have those basic ingredients, it's difficult to get the big picture. But more challenging are some of the what I would call composite measures of performance, like quality. And if you ask those who produced the Institute of Medicine report in 2001, the report that suggested the third leading cause of death in the United States was healthcare-induced injury and death. If you ask them to reproduce the numbers today, they would humbly say, we can't, because we really didn't have an accounting system to do that systematically across the complexity of the U.S. healthcare system. And they still don't. So my point is one has to look at what those systems are and then invest in them so that one can really talk about accountability with good metrics. With respect to Sharvani's question about UHC and the supply side being a litmus test, I think I would agree. And what are the disruptive innovations to make sure the private sector is part of that? And I think implicit in your question is that often the fully integrated model of public finance and provision falls short, particularly in the area of provision. And if you don't improve quality in provision and you give people, you declare universal health coverage, then it's going to be a very shallow promise. And in today's environment of growing expectations of patients, I think it's fair to say there will be a lot of distrust sown by those sorts of declarations if there aren't any improvements. So I would agree with you that we need to address the supply side. How we're doing it, the World Bank, we have something that we're developing right now called the Global Financing Facility for Every Woman and Every Child. And it's got three primary principles of financing to ensure that by 2030 we end preventable maternal and child mortality. And the three principles, I won't go through all of them, but the first is what we call smart financing. And smart financing relates to two dimensions of efficiency in systems that are often assumed but rarely attained. And the first relates to the allocation, that you buy the best interventions systematically. You make sure that across the system as a whole, that you've got the evidence to make sure that you get the most cost-effective interventions that will purchase the most health per dollar spent. That is tremendous room for improvement on that front. But the second area of smart financing that we're looking at is what we call technical efficiency. And that relates to recognition now that because of process engineering and smart ways of delivering and task sharing and things like that, you can stretch each dollar spent such that you get 25-30% more results on that dollar spent. And so together, we think that that can bring the supply side into much better focus. The private sector is absolutely fundamental in that, and so working with groups, and it's a variety of groups. We were with Kamarogo in Kenya recently, and he mobilized the private sector to work with us in the context of a consultation on the global financing facility. And I think there are at least 7 different groups representing the private sector, all of whom had very important contributions to strengthening the supply side. So my last point on this, it isn't a single point of entry. There are at least half a dozen or more different entry points to strengthen the supply side.
Would any of the other panelists like to comment?
There was a question. Go ahead. Go ahead.
I thought to add one point around, what could be a disruptive innovation in bringing the sort of private sector into UHC and that conversation is whether, Tim and others at his level of leadership in the global health economy could persuade the UN and its participants to officially endorse the role of private entities, private actors in the rollout of UHC. I think what's required is a dialogue at the political level as well, so that those ministers and those other politicians who feel it's still legitimate to say that there is no role and never will be for private healthcare, and there are some, unfortunately, I think should hear a different view from some of their colleagues. So I think that would be quite disruptive, Tim. If not impossible.
Let's take some more questions. Let's start here and then go over there.
Answer the one about about how to make patients more empowered. Yeah.
Okay.
So very simply, I think everyone who traveled in here before you came, you selected your airline, you read ratings on your airline, you checked out the rating on your hotel, even if you chose to stay, in a hotel for a certain reason. The same movement is happening to healthcare, albeit at a different rate. The technology, consumerism, and what I referred to as Uberization of healthcare is happening. Smart providers will work with it rather than against it. And in that process, individuals will get more enlightened and more empowered. And I think the horse has already left the stable on that one. Anybody who wants to try and bolt that door, it's too late. So I would say use that wave and use it positively.
You've arrived when you've become a verb.
Yeah.
Uberize me.
Yes, my question is one that you refuse to answer in spite of knowing the answer, which is, why don't they get it? I keep wondering if the reason they don't get it is because we don't know who they are, or in the alternative, that we are behaving much like the Christian church, which preaches almost exclusively to the choir. I would suggest that perhaps what we should be doing is to look for them, identify them, and perhaps together tell them that really what they are doing is not correct. In the event that I am wrong, perhaps you might know the answer to the following question. Whoever got it right? Which country has done it in a way that we could get hold of these people, take them to this country and tell them, look, it works here, let's do it together. Kindly answer my question, please.
Who is they?
Yes, who is they? My name is Frank Njenga, I come from Kenya. I'm talking about the public sector.
Public sector.
Yeah, the public sector is the they that we're looking for. Because they all seem to behave like a tribe. They behave in the same way all over the world. I could be wrong, but it looks to me like in most of Africa anyway, we are one big public tribe that responds to us who try to tell them what should be the correct way to move in the same sort of way. Thank you.
Oh, you want to do some more questions?
Yes, let's take a question from that side.
Yes, my name is John Casillas, and with Board Trust. Before that, with the Medical Banking Project, which was acquired by HIMSS, the Health Information Management System Society, which is a global health information technology association. So what Sanjita was talking about how consumers engage, the reason that we are able to do that is because the banking industry created a system that integrated with the airline reservation system. That Sabre system was the genesis of being able to jump online and do our travel. The same thing's happening in healthcare. When we put together the Medical Banking Project, we brought in over $2 billion in banking investment, direct banking investment in health information technology. So what I want to say is that healthcare is really starting to look much more like the type of business model that banks are familiar with. There's a lot of transactions. Data is going digital. And as that happens, banks are investing more in mobile technologies. You're able to do your banking mobilely. There's no reason why we can't take that same technology and port it into the healthcare space using a lot of the privacy and security mechanisms that have already built in with the banking segment. So I just want to encourage the public sector to look at commercial banking as a potential area for innovation in consumer engagement.
Thank you. Let's take one more question.
Hi, and Doctor, this is for you in the context, congratulations of what you do at USAID. And for you and for the panel, in your chart of pulling health systems together, you've got affordability, which is obviously at the core for any government. How do they expand reach, and for us in the private sector? And you have reducing out-of-pocket expenses and also lowering prices. And just in context, my name is Andres Gutierrez. I run a company called Medica Santa Carmen. We're a network of dialysis centers and kidney disease diagnostics. And we serve both the health ministry, health insurance clients that come to us. They have zero out-of-pocket when they come to us, and also private out-of-pay patients. And see this dilemma, because one of the things that we tell the government, which could go against us, is, hey, you ought to have more clinics like ours offering the service, even if that meant for the patients voting with their wallet or for the patients getting additional services that might be out of pocket. And so I think we have Discovery Health, Apollo, some experiences in South Africa, and also for yours, Doctor. What is the context? Is really the goal to reduce out of pocket, or really to get there and perhaps empower the patients to vote with their wallets?
Victor, will you start?
Can I start?
Yes.
Maybe to try and answer the question from the colleague about the issues about how them and us, that question. I think the issues that I don't have experience in Kenya in particular. In South Africa, we have what's probably called, we have a national health forum where we actually consultation forum between private and public sector. But most of these forums are basically a talk shop where basically, there's talking, but nothing really action comes out of it. I'm trying to find areas of dialogue. I mean, should have been a very good dialogue platform for private and private sector. If we had the right people here, we can talk about and try and get the message across to them. I mean, you have in our region the SADC health ministers meeting on their own, without necessarily inviting the private sector to their meetings. They're discussing SADC issues with a huge private sector component, but they're not actually involving the private sector in that discussion. We have our African health ministers meeting, not necessarily inviting the private sector to come engage them in those discussions. So somehow you find the private sector actually meeting on its own without necessarily acknowledging the presence of the private sector and inviting them to those important meetings. And I think that's the disruption that John was talking about. How can we ensure that we actually, the World Bank can assist, the IFC can assist to say, why are we having these meetings without a very important component in your sector? Why not actually invite them to the same room and discuss with them? We have the WHO having a health assembly full of ministers and policymakers. Nobody from the private sector to give a different perspective. How can we make the WHO also accept that there's a role by the private sector and involve them in a bigger role in terms of the World Health Assembly? So basically, the disruption is about forcing issues to ensure that we actually get the private sector to the table as well.
Thank you. Sangeeta.
If I can quickly add a comment. In the recent Universal Health Coverage Initiative done in India called RSBY, 34 million lives were covered over a period of 3.5 years. It was one of the most massive mobilizations of healthcare ever in a short period of time. 6,400 private providers and 2,000 public providers form the network for cashless delivery of care. So the move and the momentum is happening. It's just a period of time. You need to see that change, and it will happen. And I think sometimes you need to be the change, as Gandhi said. And to the gentleman from Kenya, I'm happy to say that in Tanzania, we formed a joint venture with the government. We will be jointly opening a clinic in the next 2 months and a hospital in the next 12 months together. So there's an invitation to private providers to come in and provision care. So I also hope that WHO is one day like Davos, a combination of private and public dialogue. But I just want to say I am an eternal optimist, and I believe the tide is turning. We just need to work harder in our own areas, and besides working in our hospitals, take the time to evangelize and socialize and talk about some of the stuff that we're doing, because the message needs to spread more.
Very good. Tim?
Just a couple of quick comments on why don't they get it. I think there is an awakening, but it's slow. It's particularly slow in the multilateral institutions. I know our own institution, this may be the first meeting where the health sector, or the sort of public side of the bank, has been more engaged in this meeting. And we've done that very deliberately over the last 6 months. This is evidence of our joint strategy. But the two parts of the institution weren't necessarily aligned in health as much as they could be. And in my analysis, we're basically shooting ourselves in the foot on both sides, right? Because the future is understanding the plurality and understanding all of those different agents who can be part of very interesting solutions in different contexts. And therefore, why would you deprive yourself of that knowledge and access to those people? But the World Health Assembly, it's a 20th century multilateral institution that hasn't woken up to the reality of health in the 21st century. Very, very slowly. They're talking about creating a Committee C. But my point would be that it's not just the private sector. You have to get citizens' voice in there as well at a minimum. And then let us get into serious detail on what constitutes the private sector, and we'll be impressed by the heterogeneity. In terms of medical banking, I think, I don't know much about the medical banking project, but I do know that there's a lot of innovation in mobile banking. And I think we heard this morning how you can link insurance payments onto that and access accounts which are backing for premium payments and things like that. And I know when I was working in Bangladesh, a tremendous amount of innovation on that front. The last point is a little bit of a problem for me, and I'm just going to challenge. It was really sort of, we're interested in UHC of reducing the out-of-pocket payments. And the question is, why not empower patients to vote with their wallets? Now, the first problem I have with that is that a lot of patients don't have wallets. They don't have that cash that would allow them to. They don't have the information to make choice. But I do believe that empowering patients is absolutely fundamental. I wish we had a stronger set of recommendations or replies to the question on how to. But I think that empowering patients to vote is what's really important. And I think part of the success of RSBY in India and other ambitious reforms towards universal health coverage is it raises patients' expectations. They say, we are entitled, and they begin to tell politicians that it's not good enough to not be accountable and to have strong systems for provision of care or accessible care or good quality care. And so I think that there is a movement that is very positive related to raising expectations around UHC, which will empower patients, but needs to be a very important part of the equation moving forward.
And just one line. I think the journey's begun. The need is to journey quickly and journey smartly. So learn from the mistakes of the rest of the world in terms of pure insurance. Move quickly into capitated care, integrate prevention. So do those quickly and scale quickly as well. Those are really the issues that we need to grapple with. Sorry.
Thanks.
Go ahead.
Yeah. Thank you. Yeah, I'm here.
Okay. Thank you.
My name is Dr. Amit Thaka. I'm from Kenya and East Africa Healthcare Federation. In keeping with the disruptive thinking, I just have 2 points really to Tim and Sangeeta and also the others. One is to do with really the financing and the other is the mobile. I started my business 20 years ago, and like many people here, they have had disruptive thinking in the growth of the business. It grew from 4 to 400 employees, from 40 patients a month to 40,000 patients a month. And one thing that I keep seeing in the slides here as well is universal healthcare coverage and the word insurance, and we keep talking about it. Isn't it time that we now start thinking differently? You know, PHI. Why don't we integrate service delivery and financing? You use the word capitation, Sangeeta. And I think supplier-induced demand is what's driving the whole aspect of us not getting there. Why don't they get it? And the whole aspect is that as long as the most expensive equipment is the doctor's pen, and if we continue rewarding sickness, you'll get sickness. Actually, doctors get paid for sickness. When your hospital is full, you make money. The more patients you see, the better you get. We still continue. I haven't seen any presentation when it comes to disruptive thinking about the trend that's taking healthcare financing to the next level towards achieving universal coverage. Why don't we ask the providers to take the risk? If you reward Apollo hospitals on, say, health, then would the number of days that a patient spends in your hospital reduce? It's just a thought. I'm trying to challenge a thought.
No, and I completely agree with the thought. I am for well care rather than sick care.
Super.
And a year ago, we actually introduced a product which said, come and have your health checkup with us.
Right.
And if you get a clean sheet out of that health check,
Right.
in case you fall sick for the next 1 year, we will cover you.
Absolutely.
And we've seen the thought process changing. And then those who we denied coverage, we said, now you sign into your lifestyle modification and we will still cover you.
Super.
So the trend is beginning, and I think it's an important trend, as important as the blurring of lines between payer and provider.
And that's why I'm particularly actually disturbed by the word insurance being used in several journals and also slides. We should change it to plans. We should call it PHP, private health plans. That's going to bring a disruptive
add medical
thought.
saving accounts to it.
Absolutely.
Because I think MSAs are a proven strategy. Singapore's shown its value. Many other countries are following it. And if you do a combination of plans, provider taking responsibility, and individual taking responsibility,
then we'll go to the next
as well as lifestyle-like discovery. It's a combination of these 4 elements which will create the new paradigm of wealth.
So that's what I wanted to ask Tim, that it might be worth looking at a global trend in private healthcare plans
I'm
becoming
sorry,
embedded towards it. But my second question was, sorry, because I got a response in between.
Yes, I know, but we have three other people
Sure.
waiting. We're running out of time.
The second one was just on mobile, you know, in terms of mobile care, Uberization. I just wanted to hear from you about where do you see health being taken to the palm of the patient? We've seen just support, but we haven't really hit the cusp where mobile health is going to revolutionize or evolve in attainment of health. What else do you think is coming next? Thank you.
Do we have a very quick response to that second point, and then we can move on?
I'll meet you at lunch. That's
Jonathan?
the quick response.
I would say that there's all kinds of technologies that are emerging and emerging very quickly. So from virtual consultations where people can consult primary care physicians from their home at any time of day or night as one example. Crowdsourcing apps where communities of people with diabetes or cancer often know more about their disease and can help each other than the physicians. Mobile payments. So, my sense is, as Sangeeta says, we're already in the middle of an incredibly fast-breaking revolution of meeting data and technology and mobile converging to hugely empower patients.
And providers who curate it will be the ones who have the differentiation with the patients. So I'll share some of our platforms with you. We're on the cusp of 2 exciting new platforms.
Let's take the last 3 questions very quickly, if we may start over here.
Yeah, Sangeeta, congratulations on the success of your telemedicine initiative. My name is Seema Chaturvedi, and I'm from the U.S. right now, originally from India. Interestingly, in speaking with the leadership of at least 4 major health systems in the U.S., the issues, and surprisingly, they're not actively engaged in telemedicine. The issues that I hear are legal responsibilities, lack of continuity of care, how do we make the economics work in terms of making that telemedicine approachable or available to a wider audience. So what is your reaction, and is this a phenomenon of the developed market looking at the developing markets for innovation in its wide acceptance and rapid rollout? So what is your reaction to these reservations provided?
Over here.
Very specifically, what changes are we seeing in statutory healthcare insurance? I mean, 34 million sounds a lot, but it's not very much in the context of a population of 1.3 billion. Absolutely. I mean, how likely is it that the Modi government is really going to introduce and roll out statutory insurance? If you were betting, what % would you put on it? And what other countries in the emerging markets have successfully introduced statutory insurance? I hear Colombia has, but I don't know any more than that. But who else is doing this properly and successfully? Specific examples would be great. Thanks.
Thank you. Last question.
Dr. Sahioun from MedLabs from Jordan. I'm going to go back to the basics and the first item, which is the harmony between the public and the private sector. In most developing countries and maybe developed countries, this harmony does not exist. And I've actually decided to put it on my bucket list. And I hope one day we'll see it. At best, you get sort of, they manage to live together. However, as everybody's saying, the private sector has the future, and scale is very important. Jordan, for example, is a small market, altogether 10 million. I tried to bring them with me, but we're busy. So you need scale. So there is a partner other than the public sector, which is important for the private sector, like was mentioned before. We started in 1993 with only 5 laboratories, and 10% of the revenue was from the insurance or insured patients. And we could not expand because we were serving people who could afford that service. But once the insurance came in, we're now 37 labs in a small country like Jordan. And what's important, it's not that the margins have increased. The margins have not increased very much. But you have served the public at large at the highest standards. and that gives you stability yourself. So I think the most important or major important partner to the private sector is the health insurance, which has to have plans together with the private sector, and they will have to work very closely together and grow together. You can't grow the private sector health without the health insurance, especially in developing countries. Thank you.
Very good. Thank you. Would our panelists like to address those questions and comment?
One-line response to Seema. Telemedicine is definitely here to stay. And if you're talking about the geography you exist in, data point is that 40% of Kaiser Permanente's outpatient visits happen virtually. And they are, a very American provider. So I think, everyone just needs to get ready for this change. The other, very interesting and potential question which was asked, and I'm not a betting person by nature, but on the Modi government, I would easily say that India will cross in the next 5 years a 50% coverage from where we are right now, which is about a 25-26% coverage. Because the momentum has begun, the models are evolving. Will it be the most appropriate, entire, wonderful care with wellness and health plans? Probably not. Will it be a significant step from where we are today with a high 80% out-of-pocket spending and health being the single largest cause of rural indebtedness? Will that dynamic change? Yes, it will.
Johnny, do you want to say just a word about the importance of health insurance?
Yeah, I couldn't agree more with the last comment. Several conversations I have and I've had in the last day are a little bit about the chicken and the egg problem in many emerging markets. We could talk about India, talk about China, many other countries where, Africa, my own continent, where you have insurers waiting for the delivery side to develop and investors in hospitals and clinics waiting for the insurers. I don't have a good answer. I think there's no one answer for any particular health economy. I do think part of the answer is in countries where both elements of the health economy are still immature, is for joint ventures between insurers and delivery systems to go in and create integrated plans along the lines that the previous person was suggesting, previous speaker. Those are undoubtedly a way to leapfrog some of the painful, inefficient history of health economies, which are highly segregated, highly fragmented, fee-for-service, supply-induced, demand-driven systems. If we can leapfrog into a future where those perverse incentives are less of the picture, I think that would be very good. But as with, I think maybe one of the most important themes of this morning has been there is no one-size-fits-all solution. And therefore, I think every country and every system will probably find different answers to how do we, is it the chicken or the egg, or is it some combination of the two?
Okay, thank you. I'm going to just try to sum up one or two themes. Oh, Tim, I'm sorry.
Yeah, there are 2 points I wanted to get to on the issue of insurance. First, the evidence that's generated in financing most of the time recommends a split between the purchaser and provider. However, as Sangeeta said, Kaiser Permanente does not have that split between purchaser and provider, and they manage actually quite well. And so I think there are no rules, but there would be some basis perhaps for looking at innovative models. Insurance, basically, I think the reason we have it in this slide refers to the need to recognize that not everybody gets sick, and therefore it makes sense to have some form of cross-subsidization, which is a protection for those who do get sick from a larger pool. It's not necessarily a prescription that there's one way to do it, and in fact, were we to do a presentation on UHC, we have a slide which says going beyond beverage and Bismarck. All right, beverage was the NHS tax system. Bismarck was the social health insurance system. And we think that in the 21st century, in low and middle income countries where you have very high rates of informality meaning people that don't get formally employed, and secondly, very low increases in tax collection in countries, to close your eyes and say, boom, we're going to have a beverage system, or boom, a Bismarck system, is not realistic. So I do think there's a lot of room for innovation on what that 21st century form of insurance looks like, and insurance in the context of the scaling the principle of cross-subsidization in systems. This last point on specific examples, I'm glad you asked that question because we have a publication coming out which is 24 case studies of countries that have scaled up reforms related to universal coverage. It's called the UNICO study. All of the case studies are available on our website, and some of those cases, for example, in Turkey, where Sharbani was working, have gone viral. I mean, they've been incredibly popular downloads in the context of what usually is the readership of bank publications, which is usually in the single digits. But you've got the whole synthesis of those 34 case studies coming out, and it covers Thailand, Brazil, Turkey, Mexico, a really very interesting set of reforms. And the synthesis is done in such a way that it pays a lot of attention to the political economy, to how these changes have taken place and how they're implemented. It's not purely a technical, prescriptive type of synthesis. So I'm advertising. I'd recommend people to look at the UNICO case studies, which will be, which are already posted, but there'll be a synthesis volume available in the next 6 weeks to 2 months.
This has been a very deep and broad discussion, so at my peril, I try to synthesize or summarize some of it. But I think that the main themes that we've heard are one size doesn't fit all. The public and the private sectors are locked in an embrace. Hopefully that's a joyful embrace. Work needs to be done for both sides to get their point across to each other. The public sector can't ignore the private sector. There's so much innovation in service delivery, so much innovation in cost efficiency, so much innovation in allied fields like technology, that this is really where things are happening. And I'll end just with a request of the IFC that they consider maybe a follow-up to the Doing Business report to maybe capture the changes that have been taking place. Maybe you already have that in the works. So that said, I'd like to thank our panel for their excellent comments. And thank you all for your time.